So we use several modalities, things as simple as slit lamp and color fundus photography, and increasingly being used nowadays are things like fundus autofluorescence, electrophysiologic tests like ERG and VEP, microperimetry, ICG is now increasingly being used, but shall we say, the kingpin of all of these imaging techniques would still be fluorescein angiography. So FA is especially useful in patients with ocular inflammation because it helps us evaluate the retinal vasculature mainly. So it helps us see things like optic disc inflammation, macular edema, retinal vasculitis, neovascularizations, and helps us detect the presence of retinal vascular inflammation even in the absence of any ophthalmoscopic abnormality. So to drive that point, I'd like us to take a look at this picture. So, Barbs, what? So, do you see anything particular?
No.
Like, how would you describe that photo?
Put this photo of the left. Put this photo of the left. It put clear media up to this ratio of 0.5. There are vessels are normal in course in caliber. There are spots noted, yellowish spots noted inferior to the macula. Yes.
So yeah,
Yes.
so yeah, nice. So essentially, for example, if you were to have faced this patient, you would really think nothing much of the retina. No, it's really unremarkable. But if we do an FA, we suddenly find a lot more findings revealed. So definitely that is not a normal angiogram. So later we'll discuss the features that are shown there. So just to drive the point na FA can reveal abnormalities even if when you don't see anything apparent just by looking at the eye. So the first thing that we need to know is when you're faced with an FA, is it inflammation, right? So perhaps you already know this parang flow chart. So when we take a look at FAs, we normally describe it whether it's a hypofluorescent or a hyperfluorescent lesion. And then for hypofluorescence, you have the two. It can either be a transmission defect or a filling defect. And then for hyperfluorescence, it can either be leakage, it can either be a window defect, or it can be due to abnormal vasculature. So in retina, there's parang causes for all of these. And in uveitis, there are also causes for all of these. So I guess this is the uveitis version of that typical flowchart that you usually see. Okay. And when you're interpreting FAs in patients with inflammation, you should also know na all of the things that you usually see in the usual retinal vascular disease can also be found in patients with uveitis, and they present on FA in exactly the same pattern as you would see them in retinal vascular disease. For example, the first picture, sort of, if I tell you parang that's a 80-year-old man that comes in with central blurring of vision, tapos there's early hyperfluorescence that increases in size and intensity, then you would think na AMD, right? And that's true because that's a CNV lesion, but in this case, it's because of PIC, not AMD. So the second picture shows you a picture of macular edema, showing you the typical petaloid pattern, and that's how macular edema presents in things like diabetic macular edema and CRVO, but it can also present in a very similar way in patients with uveitis. And then lastly, neovascularization can also be present in patients with uveitis. So yung patterns that you typically know CNV, macular edema, neovascularization, they can also appear in ocular inflammation. But what sets ocular inflammation apart? So first, so the first pattern na medyo unique in patients with ocular inflammation, and when you start reading about yung mga entities na to, this comes up always. So yung early blockage, or some books would say early hypofluorescence and late leakage in active lesions. So that pattern, early hypo and late hyper, it sort of recurs in many ocular inflammatory etiologies. But the reason why there is early hypo and late hyper sort of differs between etiologies. So let's take this first set of pictures. So here you find on the fundus photo, you see there are multiple placoid lesions all over the posterior pole, occurring in irregular patterns. The lesions are subretinal. And on FA, you find that pattern. So take a look here, parang hypo siya sa early films. And then later films, nagiging hyperfluorescent siya. So that's the pattern, early hypo and late hyper. So this is a case of AMP, acute posterior multifocal placoid pigment epitheliopathy. And the cause why this pattern occurs is because there's choriocapillaris inflammation. So that's inflammation in the choroid that sort of manifests as non-perfusion of the outer retina. That's why sa una, hypo siya. But in later films, magiging hyper siya because there's reactive leakage from the inner retina. So, but that's the pattern, early hypo and late hyper. Okay. So now we move on to this one. So this one is another, a set of pictures showing you on the first picture. The first picture, there's like a white lesion here that sort of has fuzzy borders, and then all around it there's sort of like a sort of graininess and a sort of hypopigmentation in the retina. But again, it's again a subretinal lesion. So on FA, we find that pattern again. So at first, in the early films, it's hypofluorescent. But in later films, it eventually becomes hyperfluorescent. So this is a different case now. So this is a granuloma from tuberculosis. But while it has the same pattern as the last case, iba yung mechanism niya. So in this case, the reason why that pattern occurs is because there's early blocked hypofluorescence. So blocked siya imbes na non-perfusion this time. And then as the dye circulates in the retina, it slowly seeps into the lesion because of leakage from the inflamed tissue. Okay? So again, a universal pattern, but it's a different mechanism. So last picture, showing again some parang very hindi masyadong obvious, no, but there are like discrete hypopigmented subretinal lesions all over the posterior pole involving the macula as well. And then on FA, it's the same pattern. So you have those lesions that you see on the fundus photo appear hypofluorescent in the early films, and then on later films they suddenly become hyperfluorescent. Okay, so it's the same pattern, but again, iba na naman yung mechanism niya. So in this case, SO or pwede din BKH, the main cause why this pattern occurs is because there's intact RPE with accumulated granulomatous elements causing the hypofluorescence at first, and then eventually nagkakaroon na naman ng dye leakage. Okay? So what's the main message here? So if you find on FA that you have parang a white lesion that appears hypo in early films and hyper in later films, you should think that it might be a foci of chorioretinal inflammation. Okay. So the next pattern, this one we don't see a lot, but this is one of the few posterior uveitic entities that would have a sort of, shall we say, pathognomonic pattern. So this is multiple evanescent white dot syndrome. So in nudes, there's as you know, the sort of faint white subretinal dots occurring all over the posterior pole. And then in contrast to the earlier set of pictures, this pattern would be early hyper, and then occurring in a wreath-like pattern. But instead of parang sort of increasing over time, it just remains that way. So there's early punctate hyperfluorescence and late staining corresponding to the area of the white dots. And if you see this pattern, and the pattern is very particular, it's a wreath pattern. So parang pabilog siya around the macula. That's a sort of pathognomonic for mutes. And it's I think yun lang yung uveitic entity that has a pathognomonic disease appearance on FA. Right? So then the last sign on FA that everyone should know about is vasculitis. So before we tackle vasculitis, just a quick review for the especially for the residents. So as you know, the retina has two main sources of blood supply. So there's the outer retina and then there's the inner retina. So the outer retina is supplied mainly by the choroid and choriocapillaris. And the inner retina is supplied mainly by the retinal vessels. So this is important because whether the inflammation occurs in the inner retina, it would appear different from inflammation occurring in the choroid. Okay, so and why is this so? So we take a look back at the histology of the retinal vasculature. So yung retinal vessels, so that is the retinal capillaries, they have tight junctions. So that's why the fluorescein just stays inside the retinal blood vessels. So when there is inflammation in the retinal blood vessels, those tight junctions break down and they start to and kapag nag-breakdown na sila, they can now release the fluorescein. So inflammation in the retinal vessels would appear as leakage of fluorescein. So this is reversed kapag choroidal inflammation. So yung histology kasi ng choroid, so remember the vessels of the choriocapillaris and choroid, they are fenestrated. So that means fluorescein would normally parang flow through them. But when the choroidal vessels are inflamed, those fenestrations become smaller because of swelling in the blood vascular tissue. So ngayon, baliktad. So ngayon, the fluorescein cannot just freely escape. So choroidal inflammation would now appear as hypofluorescence on FA. Okay, but again, as you guys know, and as we all know that FA is not too good in imaging in the choroidal circulation. So ICG pa rin yung better for choroidal inflammation, but that's an interesting tidbit so to help you understand the patterns on FA. Okay, so this is an example. So the picture on the right shows you retinal inflammation, so retinal vasculitis. So as you can see, the parang may leakage coming out of the blood vessels. Okay, so ngayon you also, so on the right naman, that's choroidal inflammation. So yung right is actually a case of VKH. So it presents with the classic starry sky pattern. So so pansin nyo parang imbes na regular yung sort of the regular choroidal show on FA, meron parang patches of hypofluorescence. So that's and then meron ding mga areas of leakages from reactive leakage from the RPE and outer retina. So So yan yung choroidal inflammation. But kung ICG yan, you would find specific foci of inflammation that would appear hypocyanescent. Okay? So that being said, FA excellently images retinal vasculitis. But yung patterns for choroidal inflammation or choroiditis, medyo vague yung itsura niya. Okay? And then one other thing you should know, that everyone should know, hindi porket may parang vessel na nag-leak, you just label it vasculitis, because whether the leakage comes from the artery or from the vein will actually help you sort of determine what possible etiologies that inflammation would have. So this table just shows you a sort of short list of some of the common causes for vein inflammation, so that's phlebitis, and arterial inflammation, so that's arteritis. So para madali, mainly yung viral diseases would be arteritis. So things like herpes, acute retinal necrosis, usually arteritis. So for phlebitis, yung mga common ones would be TB, sarcoidosis, Behcet's. Okay? So, sige, si Barbs ulit. Saan nanggagaling yung inflammation? Is it from the vein or from the artery or both? Vein. So sige, so if you trace it, so remember yung artery has a smaller caliber, diba? So this is an artery. So as you can see, kung i-trace nyo yung artery, very distinct yung mga parang lines niya. But if you trace the vein, yan, biglang nagkakaroon na ng fuzziness along the vein. Okay? So yan, mas obvious siya in the periphery. So this is an artery, this is a vein. So as you can see, most of the fuzziness or the leakage is on the vein, right? So yan, so this is a phlebitis. So and then you have here, what's this one? Hypofluorescent lesion. So yeah, ito, of course, you need a fundus photo, but this is from capillary dropout. So kasi because of the inflammation here, nagkakaroon ng occlusion here. So this is occlusive retinal vasculitis, specifically phlebitis. Okay? And dahil phlebitis siya, you would now think of things like TB. You won't think of things like parang viral diseases. Diba? Okay. So this one, very peculiar one. So as you can see here, medyo mahirap na, but just trust me na lang when I say that the inflammation is coming from the arteries. And then yung inflammation in particular is associated with these sort of, I'll say it na, the aneurysmal dilatations, emanating mainly from the arteries. So ito yung vein, relatively unaffected. Yung artery, very much affected with inflammation and arterial dilatations. So this is a case of Irvan. Okay. Idiopathic retinal vasculitis. Okay. So just remember these three signs. So early blockage and early hypofluorescence and late hyperfluorescence, wreath-like pattern, and then vasculitis. So if you see any of these three on an FA, you should think, oh, there might be some sort of inflammatory process going on. Okay, so once you've determined that it's inflammation or it's uveitis, so syempre refer to uveitis. But the next question is it active? Okay, kasi you can have inflammation that's active. You can also have inflammation that's already sort of burnt out. So the next thing is, how do we know that there is active inflammation on FA? So for that, this is a nice paper for everyone to read. It's a relatively old paper, 2008. So it's the scoring of fluorescein and ICG inflammatory angiographic signs for grading of posterior segment inflammation, published by the Angiography Scoring for Uveitis Working Group. So this paper really sort of set the tone for how we grade ocular inflammation across our clinical practice and even for research purposes. So this is a short summary of what you need to do. So take a look at the films at 5 to 10 minutes. Okay? So, sa uveitis, I know parang when you order your FA, you take a note which eye is the transit eye, right? But for uveitic entities or inflammatory entities in particular, the transit eye is not so important to us. Okay? Important kasi yon for things like retinal vascular disease. So things like retinal vein occlusion kasi you want to see the flow of the blood within the arteries and the veins kung may delayed filling. But inflammation kasi will not show pa in the early films. So mas important sa amin yung late films. Okay? So that's why you grade inflammation at 5 to 10 minutes. Okay? So basically yan yung mga later films. And thus, the transit eye is not so important. So there are 8 things you need to look for, and then yung 8 things na yan will have specific grading. And the higher the grade, the higher the level of inflammation. Okay, so so let's take a look at specific examples. So first, for optic disc hyperfluorescence, nandiyo ba si Rit? Okay. So kakapasok niya. So, Ollie, right? Sige. So, right and left eye. This is a mid-phase angiogram. So, at 5 to 10 minutes. Which one is normal and which one is abnormal?
On the right. On the left side. Ano eye?
Which eye is normal? Which eye is abnormal?
The right.
The right is
The right is the abnormal one.
abnormal one.
Perfect. Fluorescent.
So the left eye yan yung normal one.
Yes.
Yeah, so that's correct. So so dapat at 5 to 10 minutes, fluorescein dye should have completely escaped already from the optic disc. So dapat at 5 to 10 minutes, you should be left with a gray disc. All right? So if there's parang white sa gilid, so that's usually temporal staining or staining of the scleral rim. This one is nasal stain, temporal staining, yeah. But pwede din sa iba, but staining of the rim can be normal. But basically, the main body of the optic disc should be a sort of gray already by this time. If there's still hyperfluorescence or whiteness in the optic disc, that's a sign that there is inflammation in the disc. And this is often missed. Kasi most of the time, we take a look agad at the vessels, not parang hindi natin masyadong pinapansin yung disc. But this is what we call a hot disc, quote unquote. So, so pag sinabi namin hot disc, there's inflammation in the disc. Okay? So, yung inflammation in the disc, pwedeng ganun lang, staining. It can also be like this. So, when there's obvious optic disc leakage, with blurring of the disc margins. And this is to be differentiated from neovascularization at the disc. Okay, so yung neovascularization at the disc, so as I'm sure you guys have seen FAs of patients with diabetes na there's early focal hyperfluorescence in the very, very early films. So pag ganyan, so that's NVD. It's not really a optic disc inflammation. Okay, so that's different yung dalawang yun. But neovascularization can be a consequence of optic disc inflammation, but it's not necessarily optic disc inflammation. Okay, so just important lang for you to make that distinction when you say optic disc leakage versus neovascularization at the disc. Okay, so next, so macular leakage. So in this one, I'm sure you guys will be familiar with this na dapat the normal macula should have the foveal avascular zone, so there should be normally dapat medyo shall we say devoid of dye yung area of the fovea and macula. So any signs of leakage there is abnormal. And for inflammation, we actually grade that pa, whether it's faint, whether you have a complete ring of inflammation, whether you have a partial ring. So this is showing you a complete ring. You can also have a partial ring where there's just focal areas na there's leakage. And then the highest level would be if there is pooling forming a petaloid pattern. Okay, so if you take a look at the past few pictures, you would think na, oh, it's just macular edema, but ito, again, take a look at the disc. So it's a hot disc. So pag nakita nyo yan, you might want to think, oh, there might be an inflammatory process going on there. Okay, similar to this one, it's macular edema associated with a hot disc. Okay, so next, you have the retinal vascular leakage. So as we discussed previously, so here retinal vasculitis, you can have leakage coming from the big vessels. So that's the arcades, and you can have you can have leakage coming from the capillaries. So Oli ulit. Which leakage would represent a higher level of inflammation? Inflammation coming from the arcades or inflammation coming from the capillaries? Capillaries. The other resident, do you agree? Sige. Who votes arcades? So mag-isa ka lang. The rest of you think capillary inflammation represents a higher level of inflammation? Not sure. Okay, the correct answer is capillaries. Okay, so when there's leakage in the capillaries, that actually represents the highest level of inflammation in terms of retinal vasculitis. And that's why later, tignan ulit natin yung grading system, you will see na the score assigned for retinal capillary leakage is actually medyo skewed, mataas talaga. Kasi if you have leakage in the capillaries, ibig sabihin, very inflamed talaga yung mata ng patient. So leakage in the main vessels, while still representing inflammation, is actually a lower level compared to capillaries. Okay? But there, so you can have, like kanina, you saw na parang all of the retinal capillaries are inflamed, so that's diffuse capillary leakage. You can also have leakage just in small areas. Perhaps you guys have seen angiograms like that, na parang there's just a few areas na nagli-leak. And the buzzword that we typically look for here is you typically note the fern-like pattern. So if you take a look at yung vessels, you can imagine it's like the leaves of a fern tree. So when there's quote-unquote ferning, that represents capillary leakage. Okay? So pwedeng foci lang or focal inflammation, or you can also have diffuse inflammation. Okay? So the other points, we will skip na yung retinal non-perfusion, yung neovascularization, kasi you guys, I think, are already familiar with that. So particular for inflammation would be the pinpoint leaks. So yung pinpoint leaks naman, they are representative of choroidal inflammation. Okay, so bakit nagkaka-pinpoint leaks? So they say that the leakage is coming from the level of the RPE choriocapillaris. So in this picture, you can see here multiple areas of parang pinpoint leaks. So 1, 2, 3, 4, very diffuse area of pinpoint leakage. And then in the later film, this is the later film, there is pooling. So this is a case of VKH. Okay, so it has the starry sky pattern, and then you have the multiple pinpoint leaks, and then you have the exudative retinal detachment, kaya nagpo-pool yung dye. So one thing to note here, how can you differentiate this angiogram from VKH from multifocal CSR? Sige, yun. Pwede, unilaterality. But just by looking at the angiogram, what makes this more VKH rather than multifocal CSR? Kasi pwede din, multifocal CSR will present in exactly the same pattern. So there's a pinpoint leak, and then there's pooling in the area of the exudative retinal detachment. Yeah. Okay. So yun. So you take a look at the other features in the angiogram. So if the disc would be normal looking, so medyo mas CSR yun. But as you can see here, the disc is also inflamed. So there's inflammation in the disc also. So this points you more towards an inflammatory etiology. Okay. Of course, you will have the other features like cells and things like that. But just by looking at the angiogram, you already sort of know na, okay, parang baka may inflammation going on here. Okay. Then lastly, this is similar to what we discussed kanina. So the early hypofluorescence and late hyperfluorescence. So just a warning, when you start reading about these parang entities, you might find na magulo yung description ng mga uveitis specialists. So some would say leakage, some would say staining, and I'm sure my other uveitis colleagues would agree na magulo kasi ang mga uveitis specialists. So and walang university set upon language on how to describe these findings. But essentially, that's why mas safe to say early hypo and late hyper. Okay, so this is a case of a retinitis lesion showing you early hypofluorescence and then the late hyperfluorescence. In the ASUAG paper that we're discussing, they describe it as staining. Okay, but some books would say leakage. So yun, just a warning lang na the language used in uveitis FAs is not necessarily the same as the typical language in retinal vascular disease FAs. Okay, but it's essentially the same thing that we discussed, early hypo and late hyper. Okay. So so these are the features of inflammation and FA that you need to take a look at. So at 5 to 10 minutes, take a look at the disc, the macula, the vessels, capillary leakage, if there's retinal non-perfusion, NVD, pinpoint leaks, and then you take a look at the retinal staining. And then you can use the grading system presented here as sort of like a guide when you make your descriptions. So you can say there's diffuse staining of the disc, there's faint hyperfluorescence of the macula, things like that. You don't really have to assign a score. Scoring FAs is mainly for research purposes. So you're not expected, no one is expected naman to give the FA score of this FA is ganyan. But parang as you parang enumerate the findings on the FA, you're sort of developing na how much inflammation is present in this patient. So kasi the higher the score, medyo the more boxes are being ticked off, the higher the score is getting. So alam mo na na this is a very, very inflamed eye. Okay? And this is particularly important when you start to manage these patients and when you give treatment and when you follow up. Okay, so giving a score is sort of ideal and objective and best for research. But for clinical purposes, the crude way is just to get another FA and just put the two FAs side by side and then just sort of compare what has changed. So here is a patient with retinal vasculitis that underwent treatment with steroids, and this is also a helpful way for you to show patients that your treatment is working. So take note here that before, the optic disc had leakage with blurred margins, and then this has almost completely resolved in after treatment. All of those focal areas of retinal vascular leakage also resolved. Okay, so that's the easy way. Just put two pictures side by side and compare what has changed. Okay. So last part of the discussion would be just a little note on ultra wide field imaging. So because nowadays we're now moving towards ultra wide field imaging, it has greatly improved our ability to diagnose and manage these patients, and we now see more because of the greater field of view with the new machines. Also, sometimes these machines can actually see the retina better than even your IO. Okay, so unique with the Optos machines is it's able to actually penetrate vitreous haze up to +2 vitreous haze. So maraming mga parang images na if you take a picture using the standard camera, or if you do indirect ophthalmoscopy, it's hazy for you. But if you image it using the Optos, biglang mas marami na nakikita kasi the technology is just that good. Okay? So ito yung comparison of what we see with the standard imaging versus wide field imaging. So with your slit lamp, you usually just are able to see the disc. If you use a standard retinal camera, you can see up to 45 degrees, and then this usually comprises yung standard imaging natin where we take multiple images and put them in a montage. The newer wide field retinal imagings machines with image up to 110 degrees. So kasama dyan yung Clarus machine. So 'di ba usually sabi with two images you can have a nice field of the retina. But the Optos one, yung Optos yan yung medyo, shall I say, the standard ngayon. No financial interest, but medyo siya yung pinakamalawak na na-image at this time. Okay, so why is this important? Kasi now we're now able to see more. So in this picture, you would completely miss the peripheral vascular leakage had you just did a normal imaging modality. But with the wide field, you can now see na, oh, in the periphery, ang dami palang retinal vascular leakage. Okay, same thing here. When you relatively unremarkable retinas when you just take a picture or just take a look. But when you do an FA, kung standard field lang, medyo unremarkable din. But the periphery suddenly reveals a lot of vasculitis with capillary non-perfusion. So this is up and coming. Hopefully more centers get more ultra-wide field imaging machines. The main thing also is since we're now able to see more, this also becomes a dilemma kasi sometimes these patients don't really report anything. So, but since we saw the lesions already, the question is, oh, does it need to be treated or can it just be observed? So these are questions na are still being debated upon. Okay, so another picture just highlighting the capability of ultra-wide field imaging for this set of diseases. Okay, so let's end by just doing two exercises so that sorry, hindi pa kita kilala eh, katabi ni Barbs.
Steven.
Sige, Steven. Can you
Ito kasi.
Sige. So first describe the photo and then tell us what you see on FA.
So this is the fundus photo of the left eye. slightly hazy media with multiple areas with indistinct borders. Mm, there are areas of multiple hemorrhages
Mm-hmm.
involving the macula and also the far periphery
Mm-hmm.
with areas of uh, whitish fuzzy lesions
Mm-hmm.
along the periphery. Then on FA, we can note that there are areas of uh, hypofluorescent areas
Mm-hmm.
corresponding to the areas of hemorrhages also.
Okay, what about this one? What's
There's also, uh, it looks like vasculite.
hindi, itong
Ah,
ano parang area na to that I'm outlining.
capillary
Then
dropout.
okay. So it's parang retinal non-perfusion, capillary dropout associated with retinal vasculitis. So it's occlusive retinal vasculitis. Okay? Sige. Are you the chief president?
Yes, no.
Sige. This is for you.
So we see the fundus photo on the far leftmost photo. We see the fundus photo of the left side with clear media, distinctest borders come to this ratio of about 0.4. We note in the macula and also in the temporal periphery that there appears to be patchy uh, plaques with mix of hyperpigmentation and also absence of pigments in some areas as well.
Mm-mm.
In the fluorescein angiography, we see good disc fluorescence, good filling of vasculature. There appears to be patchy areas of hypofluorescence interspersed with hyperfluorescence corresponding to the hyperfluorescent patches on fundus photo in the early phases. These areas appear to leak in the late phases.
Okay, so let me so there are two lesions here. Nakikita niyo ba yung two lesions?
Yes.
So it's this one. So this is the first lesion. Okay, and this is the second lesion. Okay. So take a look at how they appear on the FA. So what's the difference? Yung pattern nila. So this is the first lesion. And then nagiging ganyan. Then this is the second lesion. It's this one. And it becomes like this.
Yes. Parang early blockage with late staining.
Okay. And then the second lesion,
Parang mas staining.
staining lang. So which of the two is the active lesion?
The one with early blockage and late staining.
Okay. So you have so here you have an active lesion. And then here you have an old lesion. Okay. So this is a case of macular serpiginous chororetinitis. So yeah, so kitang-kita on FA. But if you just take a look at the photo, of course you take note here that there's parang fuzzy, parang indistinct borders that sort of tells you that this is an active lesion. But on the FA, it becomes pretty obvious that there's an active lesion. Okay. So at least you know na an active lesion will present as early hypo and late hyper. Okay. So this is the summary of what we discussed today. So take note of these three findings. If you take note of any one of those, think inflammation. And then when you finally determine that it is inflammation, you take a look at the other parameters on the FA, optic disc, macular, retina, capillaries, pinpoint leaks, and retinal staining for you to be able to determine what's the level of inflammation in the eye. So in summary, so retinal imaging is very vital in the diagnosis of and management of ocular inflammation, and arguably the most important test that you should do in these patients. It's indispensable, and most of the time you even need to do serial photography and an angiography, roughly siguro depending on person to person, pero roughly every 4 to 6 months. sometimes even every 3 months, to properly assess the control of the inflammation. Okay, that's my last slide. Thank you.
Thank you very much, Albert. Do we have any questions for our speaker today? Well, ano lang, just as a comment, no, even for us retina specialists, it's very overwhelming to read angiograms ng, especially ng uveitic patients, no. So maganda yung pinakitang slide ni Albert, yung descriptions, no. Even for residents, even for consultants, the difficulty really is in the description, no. Mahirap tingnan yung isang lesion and to describe how it is. So I would advise the residents siguro to take note of the list of lesions and descriptions that was shown kanina para may magagamit kayong terms kasi um, it becomes easier if you know what the lesion looks like and how it behaves, no? So if you're looking at early hyperfluorescence and then early hypofluorescence and then nag-late hyperfluorescence. So kahit descriptive lang muna, no? The skill of reading an angiogram begins with being able to describe the lesions properly. So it may be overwhelming at first kasi even vascular lesions na mas madali, minsan nahihirapan pa tayo. What more, uveitic lesions are really, really challenging, no? Kasi there are a lot of things going on at the same time. So it's a very nice lecture on how to make things a little simpler, no, for everyone. So for the residents, really take heart take note of that of those descriptive terms para magagamit nyo. I wonder lang, what's the most common lesions that you see now na here locally? Kasi a lot of the lesions that were shown parang hindi rin masyadong common dito, di ba? Like pick, I don't see pick here, no, mudes. I've seen one in my entire career, no. So I don't know what lesions you've been seeing recently.
Ako personally, I find recently maraming mga retinal vasculitis lang. So, just that inflammation ng the blood vessels. Maybe si Dr. Ong Hansing may see more, mas matagal na siya in practice than me. Neil, if here.
Anong usual etiology nun? Mga vasculitis nyo na nakikita? May nahahanap kayong etiology?
Most of the time, wala.
Wala.
Most of the time, idiopathic yung
Okay.
etiology.
Idiopathic na lang talaga.
But kung may identified, the most common pa rin is tuberculosis.
TB pa rin.
More often than not, strangely, marami ding syphilis.
Okay. Yeah, I would think that those two are still the most common. Okay, do we have any other questions for Albert? Additional comments? No. Well, Albert, I hope that you can come to the hospital a little bit more regularly and help with the residents and do some of your procedures here, no. It's I think it's very important for the residents also to learn these things, no. Sometimes we feel that it's very, very difficult, no, but when you break it down to simpler terms kasi, in simpler processes, mas madaling matutunan. So thank you very much, Albert, and we hope to see more of you in the hospital.
Thank you.
Okay, so announcement for everyone lang. Again, it's JCI week next week, no. Just be prepared for the the accreditors, no. The other announcement is that hopefully by March 1 we will be coming out with the guidelines for the hospital supplied IOLs. We currently have a few in the pipeline, no. This is just a start and we will see muna how it goes, what the demand for it is, and then we'll take it from there, no. Dr. Leo Forrest will come up with the guidelines and orient everyone as soon as we are done. We will have monofocal, monotoric, and multifocal available in the hospital, and we'll orient you on how to go about the process. No, any announcements, Rem? Mitzi.
from me though.
Okay. So if none, thank you very much, and we will see you again in the next conference. See you next week in the JCI conference. JCI accreditation. Thank you very much. Have a good weekend. Happy Valentine's Day pala.
Thank you. Happy Valentine's Day po.
Happy Valentine's Day.